continue to make sure that this is a meeting in which we can share best practices and learn from each other. And I'm excited today to say that one of our Quality Task Force members that have served with us for many, many years and the work that they're doing at Huntsville Hospital is going to be our next topic here. Joycelyn Craighead is at Huntsville Hospital. She is going to share the journey that they've been taking there on this particular topic of high reliability and how they've tried to build that across their system. She's currently the Director of Quality at Huntsville Hospital with primary oversight for the organization's quality and patient safety program, which includes infection prevention and control, performance improvement, medical staff peer review, regulatory and accreditation services, environmental safety, and the management of clinical registries, and anything else that couldn't fit on it. Joycelyn looks like she's got her hands full. So nothing like a full day. Certainly we want to thank Joycelyn for her willingness to share so that we can all have the lessons and that have been experienced that we can take back to our organization. So Joycelyn, great to have you at the podium again, so come on up.
Let's see, clicker. Okay, I have no financial disclosures or conflicts of interest with the presentation of the materials I'll be presenting today, but I do want to let you know that this is not just about Huntsville Hospital. This is truly about our system and the journey our system, that's okay, and the journey that our system is on. So just a little bit about Huntsville Hospital health system. We encompass North Alabama, quite a bit of North Alabama, and now we're in Southern Tennessee. We include hospitals that are owned, hospitals that are managed, and hospitals that we affiliate with. So out of this 12 that are located on this slide, only 2 are not included in our original journey, and that would be Lawrence Medical, which is rural health, and also Lincoln Medical in Fayetteville, Tennessee. Lincoln just became an affiliate probably about a month and a half ago. We have been on this journey now for a little over a year, starting with Huntsville Hospital and then bringing our health system facilities along. So just a little bit about Huntsville Hospital. These are just the numbers for us. So as a system, there are about 15,000 employees that we will touch with our journey. 1,400 physicians. We deliver about 8,000 babies. 300,000 ER visits. So the opportunity for us to fail is great. I mean, let's just be honest. We're touching a lot of lives. So we have to bring our A game every time we interact with patients. Out of that 300,000 ER visits, we have over 100,000 admissions to our facilities. Now, this is not Huntsville Hospital itself, but from a system perspective. And then we have at between 2 of our facilities, just about 10,000 cath procedures. It's amazing. We already do 60,000 surgeries, and we will be opening up in, I think, 2021, a new ortho spine tower with 26 new ORs. So we are moving and shaking in North Alabama. But I bring that up to say that with moving and shaking, we always have to put safety first. So we're going to start with this video.
He's got some minor injuries. We're going to put in an IV, give him some morphine for his pain. Your little boy's going to be just fine.
Probably everybody that works in this industry has at some point or another been part of an error or a mistake, whether they realized it at the time or not.
Did you get that? Let's give him some morphine, 1 milligram IV.
And it only takes just a momentary lapse in reason or judgment. Only a second.
Verified order on patient 19, please.
What do you need?
I just need to know exactly what the doctor wants.
My biggest fear is that I'm going to let my patients down.
I don't think any person gets into the medical field with the intention of harming any patient.
Morphine's going to make your arm feel a lot better.
But the reality is we're human, so we make mistakes.
We have no heart rate. How much morphine did you give him?
We have what's called a serious safety event here on an average of every 4 days. So pick a day, I can give you a story.
They come in with the intent to do everything they can to do the right way, the way they learned, and then they make an error, and their life crumbles.
I consider every patient that comes in our door as my patient. The same way I consider my family. Nothing gets your attention like having to go and tell them, we made a mistake.
I've seen heart surgeons and neurosurgeons, tears in their eyes in my office. That's very, very sad.
You never forget.
Our patients come to us with their lives that deserve nothing less but perfect care. There isn't anything more important for us to do.
Let's design highly reliable systems that help people prevent harm.
It's the right thing to do. It makes sense. It's common sense when you learn these techniques.
For the first time, the way we achieve exceptional performance that we hold ourselves to is going to be built into the way we work.
Medicine used to be a very top-down system. It's become much more complex. Medicine is now a team sport.
When you make mistakes, the best checks and balances are the other team members.
Whether it's working in food services, environmental services, or in an administrative office like I work, every single one of us plays an important role in safe care.
This is a journey that we're going to take. We are changing culture, and we have to have the passion, and we have to have the excitement, and we have to have the tenacity to go through and do it, and we as leaders must lead it.
It's a paradigm shift. It's a change in the way that you go about doing your daily job.
If you don't change how you believe and how you think, it's not going to work.
We all have to work together because ultimately we're all here for the same goal. We're all here to take care of our patients.
What if our processes were so reliable that you couldn't possibly give the wrong medication?
What if we took the time to do it right the first time?
What if no one was ever again worried about approaching another practitioner?
What if we never had to have those hard conversations?
What if we could always think of the patient first?
I'd really love to work in that kind of world.
What if?
It's a powerful video. Very powerful video. If you're interested in that video, it's not in your slide deck. I'll make sure that I get that to Margaret. This really touched us as an organization. How many quality directors in here ask yourselves at night, is my hospital a good hospital? We've all had that thought. Is my hospital a great hospital? We have pockets of excellence. We have organizations like Healthgrades and Leapfrog and CMS that are rating us and telling us we do well. But the million-dollar question truly is, are we safe? Is my hospital a safe hospital? So Huntsville Hospital Health System started on this journey about a year ago. And we really didn't know what we were getting into, but I can tell you it has truly enlightened us and allowed us to talk to the best of the best. So in order to be the best, again, you need to talk to the best. We can see that aircraft carriers, those that work on those on a daily basis, in aviation, although we have had some international errors lately, but not domestic, and nuclear power, that they have been very successful in reducing risk. And we know this, it's evident. Wyke and Sutcliffe, in their book, Managing the Unexpected, talk about that highly reliable organizations such as these operate under very trying conditions. We do in healthcare. It's very trying, very complex systems every single day. But yet they manage to have fewer than their fair share of accidents. Can we really say that in healthcare? When you have the Institute of Medicine continually telling us that we are harming people with preventable harm as they come into our doors expecting quality care, and to leave not always exactly how they came, but that we have not harmed them while they were there. Because we know that health declines, but we don't want to be a contributor to that decline. So in Managing the Unexpected, very good book, it's a pretty easy read. They talk about 3 principles of anticipation and 3 principles of containment. So I'm quickly going to kind of go through these just to let you know from a high reliability standpoint what we are up against in healthcare, because other industries have seemed to master these principles that we yet have had the opportunity to really sink our teeth into to understand how they apply to healthcare. So the first being preoccupied with failure. So it is critical for HRO and its leaders to frantically be preoccupied with failure. They are always looking for those small errors, those small things and problems that indicate that something is lurking in the shadows. Regards to close calls and near misses, those kind of failures are considered gifts to us. We want people to report those because that is evident of our success and our ability to avoid disastrous errors. Our HRO leaders seek out and encourage our staff not only to report, but have a culture of reporting problems, errors, and their near misses every single day. And that they feel that they have this ability without any without a superior or anyone in authority taking that and holding it against them. So the sensitivity to operations. So there are 2 elements to sensitivity of operations. One, building and reinforcing accountability, and the other is finding and fixing system problems, making it difficult for people to perform effectively. Because we do. When we look at our policies and procedures, when you actually dig deep into those, sometimes we as the policymakers don't understand the sharp end and what it takes really for our staff and our employees to uphold what we've asked of them. So really looking and taking a deep dive to find those system problems. So any good HRO leader is out there, getting out from behind the desk really to see exactly what is going on out on the units and how we can be prepared to take those difficult situations and make expectations for those to know that we expect for them to be sounding boards and pay attention to what's happening on the front line. Oh, sorry. Go back. Reluctance to simplify interpretations. So intuitively, we tend to handle complex problems by simplifying our evaluation of them. So who has had an issue where you have a medication error with a nurse? Intuitively, the first thing we say is what? They didn't follow the 5 rights. Everybody had that one? Or you have something go wrong in the OR and you say, well, they didn't do their time out. But really looking intuitively to understand what happened. So at an HRO, we look for different points of view because differences hold the key to deciding the potential answers to those problems. So 2 principles of containment. We talk about containment in our commitment to resilience. HROs develop capacities to detect, contain, and bounce back when inevitable errors do occur. And that is a part of the indeterminate world. The signature of an HRO is not that we are error-free. So let's make sure we understand that. Errors are going to happen. It's not that we are error-free, but that errors don't disable and hurt somebody. It's understanding the barriers and allowing all of those processes to work from that error, that active error, reaching the end, which is our patient. Resilience is a combination of keeping errors small and improving those workarounds to keep the system functioning. People mentally are stimulated and they practice their own equivalents on such things as we call fire drills. So really working through the process so that they understand where those vulnerable states are. And then a deference to expertise. It's all about flattening out the hierarchies in the organization. We've all had those opportunities where we could have intervened, but we know that this is a difficult physician. We know that this charge nurse doesn't like to be questioned. And at that expense to the patient is the harm that occurs. So it gets back to the topic of power distance, that power gradient. HROs cultivate diversity not just because it helps them notice more in complex environments, but because it helps them do more with the complexities that they spot. So from a patient's perspective, it's pretty simple. Number 1, don't harm me. And Huntsville Hospitals wanted to be very simplistic about it. We just want to be safe. 2, care for me. Be caring. And 3, respect me. Be kind. And always in that order. Because the thing about it is you can be as nice as you want to be, but if you cut off the wrong leg, we've got a problem. You have harmed me. So it's always in that order. Don't harm me, so that's be safe. Care for me, and that's your quality outcomes. And then respect me, be kind. And it's very interesting. We took a deep dive looking at our orientation at Huntsville Hospital. We spend about an hour and a half with teaching people how to be nice. Anybody else do that? You really teach a lot about patient experience and what to say and scripting. And then when it comes to the quality piece and infection control, you probably get maybe 30 minutes combined. That's kind of not where we want to be. We really need to focus on safety. Everything starts with safety. Safety plus the performing the intended task confidently and consistently over time is what equals no harm. The next is that evidence-based performance bundle. So this is the quality, the clinical excellence. Again, you are performing the same intended acts consistently over time. Now we get into the experience piece, being patient-centered. We're again performing those intended acts consistently over time. That is what reliability is. It's those consistent acts repeatedly done over time. It's the failure prevention. Last but not least, if you ask some of your managers in the hospital, what's the number one priority of the organization? What do you think some of your managers would say? Just yell them out. I heard take care of the patient. I heard staffing and productivity. What else? Make money. What else? This side, anybody? HCAHPS. So part of the diagnostic and assessment that our consulting group worked with us on deals with the perceptions of leaders and perception of staff. So historically, when they were doing their research and talking to us about this, it's interesting of what the perception of the leaders and staff and how they don't align versus the perception from senior leadership. So you have the triad there. So you were seeing your middle managers kind of getting squunched in the middle, and finance is what is really the top thing from a middle manager standpoint. And the reason it is because staffing falls in there, utilization of supplies, you're looking at productivity, you're looking at hours worked, getting patients out. Doesn't talk about safely getting patients out, but readmissions, they're thinking of it from a financial standpoint, not pulling together the safety piece. Then you have your staff. Your staff really, they come to work to take care of patients. But the messaging that we send really is be kind to them, be nice, get them what they want. We want good scores. And then down the road, and by the way, make sure that the bed alarm is on, that they don't fall, that you give the medication on time, that you use barcode administration. So this conundrum now, we're trying to reorganize our thoughts on how we really message safety to our patients and our staff, our physicians, and our allied health professionals. We want our patients to know that safety is always first. Uh-oh, did I hit something? Oh, okay. So our journey to reliability really deals with process and people. And I will get some updated, I know there are a couple of slides in here that I ended up putting in, so we'll get those updated slides for people that are interested in them. But what we recognize is that patients suffer when they're harmed. They don't get the type of care that we know that they deserve. They don't get the outcomes that are good because care is neither compassionate and it's not connected. So really our journey to reliability is pulling these pieces together. Process, our reliability culture, and a little thing called human factors that many of us leave out when we are teaching about safety to our staff. So from a process standpoint, we are looking at evidence-based practice, focusing on things being very simple and for us to understand exactly the task at hand, and putting tactical improvements in place. For example, so sepsis. We have a sepsis bundle. We educate on the sepsis bundle. We have processes in place to ensure that when the clock starts, some of our organizations have a sepsis code team that participates in the care. Some have little alerts on their ER screen that lets you know certain things are due. So we're very good about process design and putting things in place to help us achieve certain outcomes. But from a reliability standpoint, that's pretty low on the totem pole. So adding the reliability culture on top of that, looking at how we integrate, and then how are we fair and just in holding people accountable. That A word that a lot of organizations struggle with, accountability. But as we continue and start focusing on the human factors, that's really where you see the optimization of the outcomes. Because if you don't understand the true why, and a lot of times we talk about root cause, but it's really causality, period. So sometimes when we'll say, oh, well, she didn't do the 5 rights. Yeah, that might be a portion of it, but let's think about exactly what was going on. So you had a doctor that interrupted her on the way down the hall. Then she put the medication in her pocket so she could address the physician's issue. So she was distracted. Then before she could get to the room in order to administer the medication, another patient called out needing help. So again, now she's twice removed from her original task. So it's things like that, looking at the true human factors in the environment and the behavior that leads us to a true optimization of a positive outcome. So this is something that we all from a health system are working on. And it has to do with looking at the design of these 5 important, I call them buckets, that will allow us to focus on the behavior of individuals and groups in order to have positive outcomes. So Deming tells us you have to manage a system. The system does not manage itself. And a bad system will defeat a good person every single time. And we end up creating these systems that leave our staff vulnerable, that end up hurting and harming patients. So we are looking at structure, policies and procedures, work processes, technical and or technology and the environment, and last but not least, the most important is culture. But you have to have the support of the 4 others in order for us to really define and build the culture that's going to drive the behaviors of the individuals and groups in order for us to get the positive outcomes. So I love this sign. Caution, this machine has no brain. Use your own. It's kind of a novel thought there. So this really tells us that at the end of the day, it doesn't matter if you have barcode administration. We just went through a Cerner implementation, and everyone said, oh my goodness, barcode administration, we'll never have another Miss ID again. Anybody else had that thought when they went to barcode med administration, that somebody said that? So the first thing I said is, oh, we'll have more, they'll just be a different kind. And really, that has been the case. So this reminds us that the most important person in this whole equation is the sharp end. It's that person at the bedside. That we have to value our people and our personnel because they are the most resilient part of the system. So an example would be a pre-checklist in surgery. Does that pre-checklist, is that really what makes people safe? The actual sheet of paper, is that what makes people safe? No. It's the coordinated team that works effectively with each other to make sure that everything is done before that patient hits the OR. The example of barcode scanning, it's not the technology that makes the work safe. It's not at all, because we've had incidents now where someone gives the med and then barcodes. Anybody had that at their organizations? It's kind of like that kind of defeats the purpose, but we've had that. So it's not the actual barcode scanning technology that's making patients safe, but it's the person that uses the technology the way that it is intended, that brings attention and listens to the alerts and pays attention, that is helping to keep the patient safe when giving medication. So behind each technology solution we have, there has to be a person. So we will never get rid of the human factors and the human piece of safety. So this is what I really like this, and I'm sure most people in quality have seen this, but it reminds us that we cannot completely eliminate errors because we're human, and humans will always make mistakes. But there is a science to error prevention, and that is what Huntsville Hospital Health System is focusing on, the science in error prevention, and knowing what error prevention tools that we need to use in order to prevent the errors and detect and correct the system weaknesses. So if an error occurs at the beginning, so that's your active error with a single person, it is our hope that we have taken those 5 things: structure, policy and procedure, work processes, technology environment, and built a culture that allows us to have multiple barriers so that we're not having the event of harm. We're not moving through the Swiss cheese. So that is our ultimate goal at Huntsville Hospital's health system. So in that, we have designed some prototype tools, and I'll get these to you, Margaret. I know it kind of reads like an eye chart up there. Sorry. But what we are doing is focusing on some tools that would allow us to communicate more effective and efficiently, that will allow us to be caring and kind to each other, understanding that in order for us to be safe, that we need to learn from mistakes that have happened before, because the only way that you're going to learn from them is to understand truly the human factors behind them. We have taken on, each of the hospitals spent a few months reclassifying events, really learning a different way to understand harm, looking at human factors. And the thing that's disappointing kind of for all of us is that we thought we were doing great by just capturing events. Yay, they turned them in, we know what happened. When we started reviewing, going back and looking at what had been submitted, we really didn't know anything. We were just scratching the surface based on what was reported, but not really digging deep from the human factor standpoint. So we have all learned that there's certain questions to ask, that you just don't stop with the obvious, that you have to be preoccupied with that failure in order to understand. There are leader activities as well as universal skills that everyone will be learning. Our medical staff leadership is very engaged. They have gone through probably about 4 hours of training as of right now. The entire medical staff will do training on, and when I say entire, we're talking about all 1,400 physicians that you saw on that slide. They will go through, and that will probably be part of their credentialing and privileging, that they have to do some education around the science of safety. We cannot do anything if we do not partner and collaborate with the entire health team. And this has really driven that home. We have some great transformational physicians, as well as we've got the transformational leaders from each of those hospitals here today that are working closely in order for us to be successful in this transformation of our culture. And really, that's what it boils down to. We are trying to set behavior expectations for our staff, adopting these for safety, guiding them, interacting, and with decision making. We want them to understand that you got to use your head. We want you to do the right thing the first time. And then educate and training the stakeholders, as I've mentioned. We thought we were going to meet a lot of resistance with physicians, especially because we just implemented Cerner, so they each had to go through like 12 hours of training, so just for Cerner. So we really felt that asking them to sit through additional training was going to be onerous on us. But actually, we've got a positive response. If we can keep it concise, that's the issue with physicians, time is money. But keep it concise. They understand the importance of what we are trying to do. So if you remember the beginning, we showed that powerful video on safety. How many people in here know someone by the name of John? It's just about everybody. John. Who knows somebody named Debbie? Anybody know somebody named Debbie? Anybody know a Linda? Maybe an Edward? The thing about it is, this represents harm, preventable harm, or preventable harm that resulted in death. That could be your loved one, your John, your Debbie, your Linda, that could be on this screen. Why this work is so important to us is because by putting high reliability practices in place, you have the opportunity to reduce preventable harm by 80%. So you go from this many to this many. It's powerful, powerful. Do you have any questions? I know I'm the only thing standing between you and lunch.
I'm not the yeller.
So you mentioned that you did a Cerner implementation.
I did.
Kind of in the same time frame
We
as this
did.
high reliability journey.
We did.
And, you know, retrospectively, would you have done that differently, or do you feel like it went okay? And if it did go okay, what did you do to kind of manage those two initiatives? Because those are two big deals, right?
They are two huge big deals. It's going to be a little easier for the rest of the health system because we caught the brunt of it because we were the only ones, Huntsville Hospital, Madison and Women's and Children's, we were the only ones that were going through the Cerner implementation. And I will say that our health system affiliates were great because while we were kind of dead in the midst of that, we started working at their facilities. So we did not have the same stressors. So we started the Huntsville HRO piece prior to Cerner implementation. We kind of took a break from the Huntsville part and then moved to Helen Keller and Athens and Red Bay, Decatur, followed up, I guess it was maybe November with Marshall's. So the Marshall medical centers. So it gave us that break time. I would say that I would not change it because there were principles and things that we were learning about that really helped us as we were doing some decision making with Cerner. So if anything, it's going to make the implementation piece at the affiliate hospitals much stronger because they will have had time to really learn, interpret, use, understand these principles to help them in some of the decision making when they're working through their Cerner implementation. So I don't think it was a bad thing. Stressful, but not bad.
Do you have a question?
There's a question.
Did you all change your orientation process to focus more on quality instead of the being kind
Okay,
teaching piece?
so it's not going to focus on quality. It's going to focus on safety. So we are in the process of doing that now. I think actually today our CEO is taping the orientation video just in case he can't come to every orientation, which he won't be able to. Our plan is to try to have a senior leader at each orientation, one senior leader. If not, we also have the video that will be used. But yes, the focus is changing. I think the old method was more of, well, when they get to the floor and go through the nursing part, that's when they'll learn about safety. It's not just learning about giving the right med and going through the 5 rights. It's really the science of safety. And we're trying to teach that, the human factors, and how all of those things play into every single thing we do. We were educated that on an average shift for an ICU nurse, he or she goes through about 18,000 to 20 decision tasks in a shift. That's from selecting something off of a shelf to converting something for medication administration to talking to a family to talking to a doctor. There are about 18 to 20,000 tasks that they are doing in that shift. So people really need to understand the human factors and how disruptions, how alerts, all of these other things that play into it, how they affect those decision-making skills. So that's our focus.
Anybody else? Any other questions?
It's lunchtime.
Okay, well, Joycelyn, thank you very much for sharing the journey that y'all are on there. Very good. And listening to Joycelyn, it kind of reminds me that the literature would certainly say this is not for the faint of heart, because many times as you start this journey, you will find that you have been significantly underreporting your safety episodes in your organization. And as you start this education process, this training process, you'll actually get a pretty significant bump. So you better be aware that your early results is to get an accurate baseline, not necessarily that you will see immediately that drop. So, Joycelyn, again, thank you very much for sharing the presentation. And again, I'm sure that many of you are perhaps contemplating or in the middle of similar kinds of programs, but safety certainly should be a high priority for us. It kind of reminds me of our very first I made the reference this morning with the physicians. Reminds me of our very first year of our first quality forum. We had Dr. Jim Bajian come in, who many of you recall me as a physician and an astronaut. And some of the concepts that Joycelyn just reviewed are the very same concepts that we talked about and the importance of this safety and quality journey that we were getting ready to go on. And so I'm reminded that while time passes and years go by, the fundamental work and the responsibility that we all have as leaders in our organization has really not changed. It's really about how we implement and how we execute on those things that we have unfolded on that journey in our process. So thank you all very much.